This next group of drugs are kind of loosely defined as either chemokine or cytokine targeting drugs. Okay, so there's a lot of them. To be blunt, a lot of these drugs are specific to a specific cytokine. You can subcategorize them depending on what your favorite cytokine is. Some of them are small molecules. Some of them are monoclonal antibodies. Um, there's no really kind of organizational scheme kind of beyond that. We've got some drugs that are specific to inhibiting TNF alpha, which is a really potent pro-inflammatory cytokine. Um, we've got some drugs that inhibit interleukin 1, anakinra, which is another one of those cytokines that have a really potent kind of immune-provoking activity. Okay, and where we see a lot of these specific cytokines, at least historically, has been in organ transplant and in immune suppression. So obviously, before you're going to transplant an organ, whether it be a kidney, lung, liver, etc., you're going to have to globally suppress the patient's immunity before this operation, so that they don't basically reject the organ. And as well as the HLA typing and blood matching and so forth has gotten over the years, you still have to suppress the immune system for a long period of time so that this organ does not induce an autoimmune type reaction, sometimes called graft versus host disease. So here's a couple of cytokines, IL-1, 2, interferon gamma, and TNF alpha, and what they do from a physiologic standpoint. And so, suppressing the activity of these cytokines from a clinical standpoint makes sense, not only in these patients, but also, as you'll see, in some of our tumor patients as well. Okay, and so, from a mechanistic standpoint, we can kind of subcategorize some of these cytokine inhibitors as other, drugs that have specific lymphocyte signaling pathway inhibition. So, these are kind of your classic chemotherapeutic drugs that really have potent immunosuppression. So the first one is cyclosporine. Then we'll talk about tacrolimus and sirolimus, as well as everolimus from a clinical standpoint as well. And so from a mechanism of action standpoint, this is a T cell activation diagram or cartoon, and it looks a lot complicated than it is, but basically what you're looking at here is here's your T cell in the lower portion of the diagram, and here's your antigen presenting cell. Okay, and there's two specific signals that must occur for this antigen presenting cell to basically educate this T cell and stimulate it to the point where there's an immune reaction. Okay, so signal one coming from the antigen presenting cell binds to the T cell receptor. Signal 2, which we've identified as CD80 or CD86, binds to CD28 on the T cell. Okay, so both of these two signals must occur for this T cell activity and all this activity to be activated. Okay, and so you can kind of follow the steps, which are in these black boxes here: 1, 2, 3, 4, 5. And so here what happens is, and I'll go through it once and then we'll see where the drugs kind of fit in. Excuse me. Basically you get activation of the T cell receptor through the signal 1 T cell receptor activation. That involves an influx of calcium, okay, which positively stimulates calcineurin. Okay, when calcineurin is active, you get this other pathway called the NF-ATC pathway to become activated, and then that basically crosses through the cytoplasm into the nuclear membrane and into the nuclear matrix as well, which basically stimulates a specific group of DNA sequences to become activated, and then this does one of two things. It goes back out of the nucleus, specifically looking at the activity of interleukin 2, and interleukin 2 leaves the T cell and has both local and systemic effects, both of which have the activity to induce signal 3 over here. Okay, and when signal 3 happens, then you activate this mTOR pathway, which involves T cell proliferation and growth. All right, so there's numerous and ample opportunities to pharmacologically manipulate T cell activation, and two of those are listed right here. And so let's just get a little bit closer here. Here we've got the mechanism of action of tacrolimus, okay, binding to this FK binding protein. When FK binding protein and tacrolimus are engaged, that has a negative component or a negative effect on calcineurin activity. And so when calcineurin activity is inhibited, this particular portion of the pathway is severely restricted. Okay. Cyclosporin has a different binding partner. It binds to cyclophilin. This also inhibits calcineurin activity, again through a different mechanism. But the outcome is the same. You get a reduction of this activation pathway. You don't produce IL-2, and then signal 3 does not ensue, and then the T cell growth and proliferation activation does not occur. Okay, so these are kind of your more classic immunosuppressants. Sirolimus has a similar pathway. It doesn't really affect calcineurin. However, it does it does offer inhibition of the mTOR pathway, which is listed right here. Okay. So cyclosporine and tacrolimus, we typically group these two drugs together because, again, from a mechanistic standpoint, yes, they bind to two different binding proteins here, but they have a similar physiologic outcome, and that is inhibition of calcineurin activity. And so we tend to group them together. Pharmacokinetics is listed here. Therapeutically, where do we see these drugs used? Most often in organ transplant, at least for cyclosporin. We can also see them used quite readily in rheumatoid arthritis and psoriasis. We'll examine that mechanism next week in a little bit more detail. From a tacrolimus standpoint, we're really just looking at prophylactic use of organ transplant rejection. Okay, toxicities, of course, you're looking at immunosuppression, so there's going to be drastic immune type toxicities. Patients will be at a elevated risk for infection, but cyclosporin is associated with nephro as well as neurotoxicity. Tacrolimus, similar side effects to cyclosporin, heavily neurotoxic, and you can see more the development of more post-transplant diabetes. Lots of drug interactions. Again, these drugs are biotransformed through the CYP3A4 enzyme system. So they're, your anti-fungals, some of your antibiotics, grapefruit juice, of course, are all well-known and well-described side effects. From a mechanistic standpoint, there's a lot of overlap, so you would typically give cyclosporin and tacrolimus separately. You wouldn't want to give them together. And you'd also see additive neuro and nephrotoxicity with both of these drugs in combination. And you'd also see additive nephrotoxicity with either one of these drugs combined with NSAIDs. Sirolimus, we said, has a similar mechanism of action, but its actual official target is the mTOR pathway. And so it does bind to the FK binding protein, and then that has a negative or inhibitory effect on the mTOR pathway. So this is that kind of signal 3 that was described in the previous couple slides ago, which was responsible for basically the biological activity of IL-2. Okay, and then we see a reduction in T cell proliferation. From a historical standpoint, this is a little bit interesting. Sirolimus is actually fermented byproduct from mold. We used to actually call the actual mold that produced it rapamycin. And so this mTOR pathway stands for mammalian target of rapamycin. So we actually discovered this pathway through the use of this drug. And so that's kind of a nice anecdotal mnemonic. Hyperlipidemia is really kind of the most common but adverse side effect. And this drug has a really, much longer half-life than the other drugs, cyclosporin and tacrolimus. Okay. And so the IL-2 receptor is really an important signaling molecular target to perturb in these patients. So here's a nice kind of schematic of the interleukin-2 receptor and the activity and what it does internally. And so you can see these specific drug targets. This is a different diagram, of course, but those drug targets are listed there as well. And just to really kind of remind you that IL-2 is an important molecular target to achieve um, immune suppression. So this is a summary diagram of the IL-2 receptor. Let's move on to everolimus. There we go. So everolimus closely resembles sirolimus chemically, but clinically has really different pharmacokinetics. This is one of those mTOR inhibitors. The cell cycle phase is halted in the G1 to the S phase. Um, And so clinically, this is used for postmenopausal women with the HER2 um, negative breast cancers, adults that have those progressive neuroendocrine tumors or PNETs, advanced cell carcinomas, and some other tumors that are listed there. So this is kind of where we've kind of crossed the line from, classic immunosuppression using these drugs for like transplant type of reactions to more targeted approaches to, shutting down uh, T cell activity. And again, I wanted to remind you, we're looking at T cell activity. We're looking at the activity of interleukin 2 on a T cell. So obviously, T cells have a negative type of outcome in terms of these diseases, which warrants their inhibition. Okay, so that's kind of looking at some of the cytokine and uh, chemokine type inhibiting drugs, and we will go on to some other molecular targets now.